Hi guys, I'm Alex. I'm the critical care educator here at Kettering Health Dayton. Today we're going to be talking about what we need to do in the event our patient who has a trach and it gets dislodged. First, we need to make sure that we have all the appropriate supplies at the bedside. One, we want the arbitrator hanging up on the wall. There's also one in our trach box. And we want to make sure that we have the correct size trach. So our patient today is going to have a 6, and so we want a size 6 at the bedside, but we also want one size lower. So we would get a size 5, and we'd make sure size 5 is at the bedside as well. We want to make sure that we have a 10 cc or 20 cc syringe to inflate our balloon. We want lubrication for inserting the trach. We want to make sure that we have fresh trach ties. We want to make sure that we have suction set up. And most importantly, we want to make sure that we have our ambu bag. And we have a mask for our ambu bag as well. So, we walk into our patient's room, we perform our hand hygiene, and we notice that our patient's trach is dislodged and their oxygen is lowering. So we need to act quickly. We have about 20 seconds to replace the patient's trach. So what do we need to do? Well, we're going to grab our regular size, or size that the patient has. So this guy has a size 6, so we're going to try and place a size 6. And we're going to grab our obturator. There should be an obturator in each of the trach boxes. But we also want to make sure that there's one at the bedside. So once we open up our box, we're going to make sure that our balloon doesn't deflate and doesn't have any holes in it. So we're going to place 20 cc's of air into our balloon, and that is how much air that is needed in these cuffs. Now I'm going to just assess, make sure that there's no air leaks. There's not. So I'm going to withdraw my air. I'll lubricate my trach. I'll place my obturator in the trach. And now I'm going to attempt to insert the trach. So I'm going to come to my patient. I'm going to try to insert. If I'm meeting any resistance, I don't want to force it in there. If I force it in there, it could cause trauma to the trach site, and the skin surrounding the neck and the chest and the face could develop crepitus or subcutaneous emphysema. So say, for instance, I'm meeting that resistance, my stoma hole is closing, because our stoma holes can close very quickly. Then I'm going to attempt to grab my size 5, my size smaller, and reattempt placing my trach. So let's say that all went well and we got our trach placed. Now we're placed, and I can take my obturator out, and if my patient's O2 sats are low, I can bag my patient, and we'll connect right to the trach. We'll also want to make sure that our oxygen is connected. At this time, after you get our trach in place, you want to inflate the balloon as well. Now, say for instance our trach doesn't go in. We have complete difficulties, we're unable to get it in. All that we need to do at that point, we need to bag the patient, because we need to ventilate them. So we'll take our ambu bag. Again, we want to make sure that we're hooked up to oxygen. And we'll turn our oxygen all the way up to 15 liters. We'll get this placed correctly, and I want to take a glove thumb underneath the stoma site while we're bagging. Ideally, we would want to take 4x4s, use those 4x4s to place underneath the stoma. In an emergency situation, it is okay to use a glove thumb to place over the stoma site while we're delivering our ventilations to the patient. After, if it's in place or whatnot, have someone take their stethoscope. auscultate, make sure that we have lung sounds in all of our lung fields. By this point, all of our respiratory team, our pulmonologists, everyone should be at bedside to assist. And if not, now we know what to do. A couple other things just to make note of. One is if our patient has a fresh trach, we cannot replace, and it dislodges, we cannot replace the trach up to 7 days post-surgery. We need ENT to place the trach. So if the trach dislodges and they're a fresh surgical patient, then we just bag the patient until ENT arrives. If the patient has had a laryngectomy, we want to make sure that we get pulmonology in right away, because bagging the patient will not provide appropriate ventilations for where the surgery was. Hopefully this was helpful. If you have any questions, please feel free to reach out to myself or any other educator or a respiratory therapy or pulmonology team. Thank you very much.